sidey. Okay, let me grab a plate.
I made it a little slow.
We're still here.
Oh.
Okay. So it's going to be the 10 by 12 that we will be using. Okay. And oh, I need to grab one more thing. Sorry, I'll take care of that.
Say hi.
You're filming already?
Yep. She already said what plate to use.
And I know that Jessica in particular will appreciate this. So because your patient's face does need to touch the board, what my clinical preceptor taught me was to put a paper towel where the patient would be putting their face. Okay? The reason why the paper towel may be preferred is because then your patient knows for a fact that it's a clean surface they're touching. Even if you wipe the board down with an alcohol wipe, if the patient doesn't see it, they might be a little timid to put their face on, and let's face it, there's a lot of techs that just don't wipe the board down. So this is what I was taught to do to make sure that the surface is always clean for your patient, and it brings a certain level of comfort. I always have my patients sitting for a few reasons, so you can have a seat mic, and you're going to be facing the board. You don't have to put your face against the board yet. I'll tell you when.
Or kiss the towel.
So I always put my patient sitting because of multiple reasons. Number one, it keeps them from swaying side to side, because when a patient's standing, they can't stay still for the most part. Even with their face touching the board, they'll be swaying all over the place. At least when they're sitting, it keeps their bottom half from moving all over the place, so that you can just focus on the skull. The skull can move in all different directions, so you have to be careful, because now you have to deal with tilt or rotation. Okay, that's what makes the skull so difficult, is because now there's a lot more area where the patient could move or turn, and then it throws your image off. And any slight rotation over or under shows up on your x-ray. Okay, so that's what makes it really difficult. And then my last reason for having my patients sit is because a lot of these views have a really steep angle, or at least one of the views may have a steep angle. So if you have a patient who's pretty tall, if they're standing, you're not going to be able to get above them. Your tube will get maxed out, but if they're sitting, you'll be able to get it, no problem. So even if Mike was Shaquille O'Neal, I could get his picture. All right. Why do you guys think a PA skull would be better than AP?
Because you're not going through my eyeballs.
Yes. So Mike beat us to the punch. It's to reduce your lens dose, because your eyes are very sensitive to radiation. Oh, here, let me get this. So what are some things that can happen if you get too much radiation or dose to the eyes? Is you can get cataracts. So I don't know if you guys have heard, but there's, especially like IR techs, a lot of them get cataracts earlier than most people because of the dose that they're constantly getting exposed to. Okay. Also, you have your thyroid, so that reduces its dose. Do you guys think the brain is sensitive or not very sensitive to radiation?
Sensitive.
It's actually the least sensitive part of your body to radiation. And it's because by age 25, your brain stops developing. You don't have any more new undifferentiated cells. And so if the brain has a DNA strand break, it's not going to be reproducing new cells that could potentially be mutated. So the areas that are more sensitive would be like the reproductive area, because you have a lot of cells that are undifferentiated. So if they have a DNA strand break, it can cause a much more impactful mutation, whereas your brain's not developing anymore, so you're not going to have those mutations. Okay? I know it's kind of weird. So now I'm going to have Mike position for the skull. It's really, really important. Here, you can lean back. Sorry. I'm getting ahead of myself. It's really, really important that you guys put a marker on your image. I have had a tech when I first started as a technologist, there was someone that sabotaged my images, and thank God I had my marker on my pictures. So what happened was I did a skull series on a patient. Their status started declining, so I ran them to the ER room and let the nurse know what was going on. When I came back, my images were sent, except they weren't even how I took them. They were purposefully flipped backwards, upside down, all over the place. Luckily, because I had my marker on the images, I was able to go into Synapse and fix my images so they were oriented correctly.
That's so mean.
Yeah, no, and that guy's really lucky I didn't go to HR. I did go to my manager for that, but yeah, he's really lucky I did not go to HR.
Also, like,
I know.
it's dangerous for the patient. too.
Right.
It doesn't do the patient any good.
Yeah, he had some issues,
Yeah,
to
it's
say
too
the
sick.
least.
It's like too sick.
But yeah, he could have suspended the exam. But maybe, someone coming through meant to suspend and they accidentally send your images. Not everyone's doing something intentional. That person was a particular type of
Nefarious
person.
character.
Yeah. So the skull is going to be almost impossible to tell which side is which, unless they have like a filling on one side, or there's a foreign body on one side, or they have a nose ring that they can't take out, something definitive. But most patients, you won't have that. Okay. So I'm going to show you guys mostly the PA views. Okay. So I'm going to have you look straight. You're going to put the tip of your nose on the board. Okay, there. And then, I'm sorry, Mike, I keep getting ahead of myself. So there's 3 main areas to look for when you guys are positioning your patient. You have your glabella, that's in between your eyebrows. You have your nasion, which is where your nose connects to the skull. And then you have your canthion, which is right below your nose, where it's connecting to your upper lip. Okay, those are the 3 areas you're going to really want to make sure you know when you're positioning the skull. Okay, now you can face the board. Sorry about all that. So I'm going to show you guys the Caldwell. Initially, this picture is going to go through the nasion. Okay, you can do it perpendicular to the board, or you can throw a 15-degree caudal angle. Most places want you to do the 15-degree caudal angle when you're doing this image. However, if you guys are doing a sinus series and they want this picture, you always have to go 90 degrees straight onto the board. The reason for that is because you're looking for air fluid levels, and if you throw an angle on there, it's going to throw off those levels. Oh, whoops. Okay. So now I'm going to show you guys perpendicular first. I'm going to make sure Mike is nice in position. Okay. And then tilt your chin down just a little bit. Not too much. That's way too much. Yeah, right there. Perfect. Okay. And then you do need to come behind your patient. Make sure that they're not rotated. If you have patients that are a little weird about you touching their head, it can be really difficult. A lot of times I use the back of my hands to help position, and that tends to make the patient a little more comfortable. Mike is really easy to collimate to because he doesn't have all this big hair, to factor in. You can pretty much see where the top of his skull is. Also, there's beam divergence, so you're going to have a lot more area than it looks like. You can actually collimate straight against the lines of his head, and you'll still get everything. It's going to look like you have a lot of space around the skull, even when you collimate this tight. Okay. Again, for perpendicular, that's for if you're looking at sinuses. And then I'm going to show you guys the 15-degree angle. It's also going to go through the nasion. Okay. And then we're going to move the board down. Sorry, Mike. There we are. Okay. Actually, I need to come down a bit. Okay, sorry, I'm going to come down a little bit more. There we go. All right. And so that would be our Caldwell, PA Caldwell, with the 15-degree angle. Okay. All right, now I'm gonna show you guys the Waters view. A lot of doctors like to use this for nasal bones or looking at the sinuses because you can see the maxillary sinuses really nice on this picture. So for this one, you're gonna have your patient put their chin on the board. They're gonna, yep. If you have a little kid, you might need them to extend a little more than normal. And it's just because of their body and the way their skull is shaped. If you don't have them exaggerate that angle, it's gonna look like a Caldwell. So this one is gonna be 90 degrees straight on. Now you have your patient moving their head and it's gonna go out via Canthion, so right below the nose. Okay, I'm gonna bring this up. There we are, we can collimate. And that would be our Waters. Okay.
Is this the one that kind of looks like a moon?
Yeah, I think so.
I'm not sure, but I know you can see the nasal septum really well because their head is turned up, and then you can see that nice line. So if there's a septum deviation, you would see it really clearly on this picture. Okay, you can relax, Mike. And then I'm going to show you guys the lateral skull. So you're going to be obliqued towards the board, and then you're going to turn your head to the side. So no matter what, there's going to be OID in this picture. You can't get around it, but this is how you're going to get your patient the straightest and closest to the board. So they need to throw their shoulders back, and then you do need to make sure that they're straight. What you can do is you can have them follow your finger and turn their head. Okay, right there, don't move. Or you're just going to have to touch their head and turn them to where you need them. Some patients, because they know you're going to be x-raying the side of their head, they want to do a really good job for you and they tilt their head into the board. You do not want any kind of tilt in this picture. And you can tell you have a really good lateral skull if your sella turcica is nice and superimposed. Okay? And then your picture is going to be a few inches above the EAM. I really like stools with wheels because then I can move my patient easier. Okay. All right, and then we're gonna just move your head slightly. Here, move your head a little bit, turn a little bit. There we go.
These are all 40 HSID, right?
Yes. And then because of the OID, you may need to open up your collimation, and then you do need to turn your plate to be landscape for the lateral. Okay. All right. So you're only about 2 inches above. I'm gonna scoot you back. Here, let me just look straight ahead, and then let me move you. Right there. Sorry. Okay, and that would be our lateral skull. If you were doing sinuses, you would have your patient push back because the sinuses aren't going to go back into the rest of the skull. It's going to be in the front facial bone portion of your face. Okay, so you can collimate. You bring this down so that you're just a little anterior to the EAM now. And this is the only view where you can see all 4 sinuses. Okay, the ART loves that type of question. So the lateral, I guess it's more lateral facial bone for sinuses. You can see all 4 sinuses. Okay, you have your maxillary, frontal, ethmoid, and sphenoid sinuses. All right, so that's our lateral. Let me show you the nasal bone real quick. So I'm gonna have you scoot back, right there. And you're gonna want to oblique your shoulders and bring your head a little bit closer, and then turn. Yeah, there we go. Perfect. So basically, for the nasal bones, you don't need a bunch of area to X-ray. You're gonna be right where the nose articulates with the skull. Okay. Another thing we'll need to do, because it's such a small piece of bone, and you don't want your AEC to go off too far, you will need to take the grid out. Okay? So anytime you do a lateral nasal bone, you always take the grid out. For the PA Waters, you don't need to because it's still a pretty thick body part to go through. But anytime you're doing lateral nasal bones, I can't tell you how many I've seen burned out overexposed, and it's because the techs always forget to take the grit out, okay? And then make sure you're putting it in correctly so that the next tech doesn't get mad at you. Alright, I'll do this after. I'll put it back after. I don't want to get Mike. Okay, and then when you guys are labeling your marker for the lateral, it's always the downside. If you guys are doing a lateral skull or facial bone or whatever, you always do the affected side down. So if he had a foreign body on his right side, you'd be doing a right lateral. Okay? And that's so that you have better detail and that part of the body is closest to the IR. Okay? Now I'm going to show you guys two more pictures. I'll show you guys the towns. So you're going to put your back on the board. This one you're going to want your cassette portrait. Actually, for both of these you'll want it portrait. Okay, this is going to go way down. Here, can you scoot forward? There we go. All right. And then for this one, it's going to be a pretty steep angle. Okay, you're going to be about 2 inches above the glabella, and this one is really good, especially for the mandible, because it elongates it, and so if there's any fracture, you'd be able to see it pretty clearly. So I'm going to go down to 60 degrees because that's 30. And then I'm going to bring this way up. So this particular view is exactly why you have your patient sitting down, okay? And then Mike, I'm going to have you put your back all the way against the board. If you need to scoot the chair away from the board, you can. And then what you're going to do, with your head against the board, you're going to tuck your chin down. So don't let, yep. So this can be really difficult for patients to do. And a lot of techs, when they mess up the Townes view, it's because the patient's head moves away from the board because they don't understand to tuck their chin in and be leaning into the board, okay? So I'm gonna be a little bit above the glabella. I'm gonna move you so that you're centered. There we are. And I'm gonna bring the board up, okay? There we are. I don't wanna collimate too much, too tightly, because you do wanna see the entire mandible for these pictures, okay? This picture also gives you a really nice view of the skull. You can see the complete outer portion, so if there's a fracture, this would be your money shot in seeing that, because the skull is completely independent of all other anatomy, okay? All right, any questions? Perfect. So now I'm gonna show you guys the SMV. This is by far the most difficult picture. When I was a student, I always wanted to be the patient to see what the positions felt like, and this was the most difficult one out of every single position I've done for x-ray, okay? So what you're gonna do, you're gonna have the patient lean away, and they're gonna put the top part of their head against the board. You need to be all the way flat. So you might need to lean, I know. Yep, keep going. More? Yep. So turn your chin up. Yeah, there we go. And even this isn't as flush against the board as we need. He's still a little too angled, okay? This is usually what most patients are able to do. You can relax. I know it's really hard to hold it. I'll show you guys what it looks like tabletop as well.
So we're able to use the board, right, to like angle it also, or no?
Don't get ahead of me. Let me finish. So what I would do for this, once the head is nice and flat against the board, you're going to be angling between both gonyon of your mandible. So you're going to be right in the center, right where your jawbone is, where you have that angle. You're going to be in the center. That's your central point. This is really good for seeing the zygomatic arches. So if you guys have zygomatic arch protocol, usually they want the SMV for that. Okay? I do not recommend angling the board because, I mean, you know what, maybe actually you might be able to do that. The only thing is you have to make sure that your tube matches the angle exactly. So it is better to keep everything 90 and have your patient move, but obviously you're going to be limited with what your patient can do, right? So I'm going to show you what it looks like tabletop, especially if you have an elderly patient where that's just not going to happen, okay?